We are Group 1, and our topic is anemias, specifically deficiencies in iron, vitamin B12, and folic acid. First is iron deficiency. This is the most prevalent nutritional deficiency across the globe. It's more common in women, partly due to the blood loss that occurs during menopause. It's also common in African Americans and the elderly. Iron is essential to forming hemoglobin, which is the part of the red blood cell that carries oxygen throughout the body. Iron is also stored in the liver as ferritin, and when the body becomes deficient, the kidneys decrease production of the erythropoietin, which is an essential hormone for red blood cell production. So this, of course, leads to a decreased amount of circulating red blood cells and results in anemia. This has multiple causes, including hemorrhage, inadequate dietary intake, and diseases that hinder the absorption of iron in the GI system, which include celiac disease, Crohn's disease, and GI cancers. And it can also be a side effect of certain medications, including antacids, proton pump inhibitors, aspirin, and NSAIDs. Next is B12 deficiency. This can be caused by either inadequate intake or disorders that cause malabsorption. It is more common in the elderly due to the gradual atrophy of the stomach, as well as decreased gastric acid production. Risk factors for this deficiency are similar to that of iron deficiency, which include gastrointestinal resection, Crohn's disease, celiac disease, autoimmune disorders such as AIDS, and alcoholism as well. It can also be a side effect of medications that decrease gastric acid secretion, like proton pump inhibitors and H2 blockers. B12 is commonly found in meat, so other risk factors would include low socioeconomic status, as well as being a vegan or a vegetarian. And B12 is used in the development of the myelin sheath in the nervous system, and it's also involved in the Krebs cycle, where it helps to produce certain neurotransmitters and phospholipids that contribute to the overall function of the nervous system. The last deficiency is folic acid deficiency. Folic acid is a B vitamin that's essential in DNA synthesis, as well as the production of heme, which is the part of hemoglobin that contains iron. This is typically a result of insufficient dietary intake, but it can also be caused by chronic conditions such as Crohn's, celiac disease, certain GI cancers, and also a result of GI surgeries. It can also be a side effect of medications such as methotrexate. Folic acid deficiency can result in low hemoglobin levels, and in the case of pregnant women, it can cause neural tube defects in the fetus, as well as other birth defects such as spina bifida, ancephaly, and a cleft palate or lip. And it can also lead to decreased levels of neurotransmitters in the newborn, which could cause developmental delays. And another possible cause of folic acid deficiency is alcoholism, due to the fact that alcohol inhibits the intake of folate.
Within the three different anemias, there are several symptoms that are consistent throughout, those being fatigue, dizziness, pallor, tachycardia, and tachypnea. Also, shortness of breath and glossitis, which is only prevalent in iron and B12 deficiencies. Glossitis is due to the effects anemia has on regeneration of mucous membranes and GI tract, causing fissures in the corners of the mouth and shininess on the tongue. More specifically now, the signs and symptoms of iron deficiency can be hypoxia due to the inadequate oxygenation of body's tissues from decreased hemoglobin levels. Koilonchias is another symptom unique to iron deficiency that is usually from long-term iron deficiency. It creates soft and malleable fingernails. Moving on to B12 deficiency. Some of the signs and symptoms specific to this deficiency are spinal cord degeneration, peripheral neuropathy, altered mental status, depression, numbness and tingling of the hands, which is due to demyelination, which is when the protective coating on nerve cells receive damage. This is also usually the first neurological clinical manifestation. There can also be some visual damage due to nerve atrophy in the eyes. Skipping down to Lermity sign, which is an electric shock sensation produced by neck flexion. CNS depression, which can lead to mood swings and impaired balance. Dementia resembling Alzheimer's. Visual disturbances, specifically yellow and blue blindness. Low-grade fever, and tinnitus. Lastly, the signs and symptoms that are specific to folic acid deficiency are increased risk for bleeding, which is due to the decreased number of platelets, also called pancytopenia, confusion and disorientation, and neural tube defects in infants whose mothers are deficient in folic acid. With that, folic acid replacement is something that may be able to reverse anemia that occurs with B12 deficiency, but neurological degeneration that occurs in B12 deficiency may not be reversible.
Iron deficiency anemia is diagnosed by decreased serum ferritin levels in a blood test. The therapeutic management for this anemia involves increasing iron intake in the diet and increasing vitamin C intake, which improves iron absorption. Iron supplementation, which consists of oral IM or IV routes, is also sometimes needed. Parenteral supplementation is only used in severe cases of GI distress, a malabsorption disorder, or another disorder which interferes with oral supplement absorption. It is important to remember that IV iron is cardiotoxic and to monitor for these side effects. The nurse should also monitor for nausea, abdominal discomfort, constipation, and diarrhea.
Vitamin B12 deficiency anemia is diagnosed by a serum B12 assay test, but it is possible for a false negative to be caused by liver disease or lymphoma. Prevention is key with this anemia, and therapeutic management is most focused on increased intake of vitamin B12 in the diet, which is mostly animal derived. Once deficiency is determined, weekly vitamin B12 injections are required. It is important to monitor folic acid use and nitrous oxide use with vitamin B12 deficiency, as folic acid use can resolve the anemia but will allow brain degeneration to continue, and nitrous oxide will deactivate vitamin B12 in the body. It is also important to keep in mind that peripheral neuropathy can result from vitamin B12 deficiency anemia.
Folic acid deficiency anemia is diagnosed by a CBC test, and therapeutic management is focused on increasing folic acid intake in the diet and using supplementation. Supplementation is especially recommended for pregnant people who should consume 400 micrograms a day, children in the first year of life, patients with a history of gastrointestinal reactions, and individuals with a history of excessive alcohol use. There are some medications that can decrease folic acid absorption, such as oral contraceptives, metformin, and some chemotherapeutic agents. It is important to remember that folic acid supplementation can resolve vitamin B12 deficiency anemia, but allow brain degeneration to continue. This is why it is especially important to determine that it is folic acid deficiency anemia and not misdiagnosed vitamin B12 deficiency anemia.
Next, we're going to talk about the similarities and differences in the nursing care we would provide to these patients. You want to be monitoring their vital signs, specifically looking out for tachypnea and tachycardia if the lungs and heart are compensating for decreased oxygenation. You also want to be aware if the patient is having any fatigue, pallor, shortness of breath, which would indicate inadequate tissue perfusion or hypoxia. For labs, we would be looking at complete blood count for all of these anemic patients, specifically looking at their hemoglobin and hematocrit, their medication or supplement regimen, making sure that they adhere and that they understand what might be appropriate for them to be taking. This leads us into teaching, which is super important with these patients. We'll touch more on the teaching aspects specifically in a little bit. And finally, as nurses, it's important that we're evaluating the care outcomes. With each of these types of anemia, it's possible for them to be reversed, so that is the ultimate goal for our patients. When it comes to differences in care that you'll be providing, starting with iron deficiency, as the nurse, we would want to assess level of consciousness. Alterations occur from decreased iron levels that cause decreased O2 to the brain. Especially in children, it's important to look out for this because if prolonged iron deficiency anemia is present in a child's developing brain, cognitive impairment is possible. You also want to minimize blood loss in these patients because the decrease of any more iron and hemoglobin would worsen manifestations. Excessive bleeding with menstruation may be controlled with hormonal meds. For labs, we would be looking at serum ferritin levels, and moving on to vitamin B12 deficiency, we want to be assessing the pain level in our patients due to peripheral neuropathy, making sure that they are not a fall risk because confusion, coordination impairment, balance impairment, and visual disturbances are all possible symptoms of vitamin B12 deficiency that may put the patient at risk for falls. monitoring their I&O, making sure that constipation, diarrhea, and or anorexia are noted because they can all affect absorption of vitamin B12 and worsen the problem. You also want to make sure that you monitor any use of nitrous oxide, which might be used for anesthesia, but it inactivates vitamin B12. So making sure before using nitrous oxide that your patient does not have vitamin 12 deficiency. And you want to be looking at vitamin B12 serum assay blood test and if they have an elevated serum and urine MMA, which would also indicate vitamin B12 deficiency. Finally, with folic acid, looking at confusion and disorientation, which are neurological manifestations from decreased oxygen to the central nervous system, and confirming that before administering folic acid that your patient doesn't have vitamin B12 deficiency, because folic acid will resolve the anemia, but neurological degeneration from vitamin B12 will continue. Finally, red blood cell folate acid level reflects the serum folate level over the past 3 months and is therefore the best indicator for folic acid deficiency.
As we move into talking about patient teaching, we find many similarities between these three types of deficiencies. The main teaching point for each deficiency involves increasing sources in their everyday diet. Good dietary sources of iron are red meats, dark green leafy vegetables, beans, and iron-fortified cereals and breads. For vitamin B12, some foods include meat, seafood, eggs, and dairy products. For folic acid, green leafy vegetables, bran, and nuts would all be good sources. In addition, for all three of these deficiencies, you should teach your patient about adding supplements to their diet. If your patient is pregnant, prenatal teaching is vital with any of these deficiencies to make sure they are getting a sufficient amount of each to avoid any complications with their baby, such as lower birth weight, preterm labor, and neural tube defects. Lastly, although they differ slightly between deficiencies, it is very important to teach your patient to report any significant symptoms to their healthcare provider. The two common symptoms for all three are excessive fatigue and shortness of breath. Now let's move on to the differences in patient teachings. For iron deficiency, it is important to teach your patient that any lead exposure can cause significant cognitive and developmental abnormalities, specifically in children. For vitamin B12 deficiency, you should teach your patients that if they are having radiation treatment for cancer, their need for vitamin B12 will be increased, and therefore they may not respond to the treatment as well. In addition, any patients taking acid-reducing medications may develop vitamin B12 deficiency over time because of a decrease in parietal cell function and therefore may want to increase this in their diet.
Last but not least, what we have here is a research article related to our topic on anemia. This study was done in a geriatric clinic and a teaching hospital in Punjab, India, studying the prevalence of anemia and macronutrient deficiency in the elderly. We are going to begin by identifying the PICO question, or the question the research team of the article asked. What is the prevalence, patterns of anemia, and hematopoietic nutrient status of a geriatric population attending a hospital versus the geriatric population in the community? From this, we can form our own PICO question. In the geriatric population seeking medical care, how does the prevalence of anemia differ compared to the community geriatric population during the hospital stay? The research yielded these results in take-home points. 1,800 out of 2,540, or 71%, of the informed screened geriatric patients in the clinic were found to be anemic, which the article states is higher than compared to the World Health Organization's report in 2000, that states 50% of geriatrics in developing countries are anemic. This large difference can be explained by the hospital setting that the study was done in. People are coming in because there's something wrong with them. From this data, it was found that anemia was found to be more prevalent in males than females, which was in line with the previous mentioned World Health Organization's report. Geriatric patients were broken down into three categories: young-old, ages 60 to 69, middle-old, ages 70 to 79, and old-old, ages 80 and over. It was found that anemia was more prevalent in older age groups, comparing to a 1980 study on nutrition in the lifespan by Virginia Beale, who has worked with CDC and FDA, and was actually a UMass professor at one point. Of the 1,800 anemic patients, 56% had normocytic anemia, which means they had normal-sized red blood cells, but a low amount of them. Almost a quarter of these patients tested positive for blood in their stool. 31% of anemic patients had an iron deficiency, which meant less than 15 nanograms per milliliter of blood. Iron deficiency was the most common deficiency compared to vitamin B12 and folate in the study, which was in agreement with a study done in 2004 by the National Institute of Health, with the same purpose of determining the prevalence of anemia in the elderly population. Vitamin B12 and folate affected around 6 to 7% of the population each. When it comes to evaluating the strength of the study's results, I would say they are acceptable. First of all, the journal the article was published in, the International Journal of Medical and Dental Sciences, is a biannual peer-reviewed journal. The study has gone through an extensive process of getting peer-reviewed by experts in their own field with plenty of experience in the subject matter. In general, peer-reviewed studies are considered higher quality. The article was also well-written, concise, grammatically correct, and avoids the use of jargon. It was also well laid out and organized. For example, the abstract offers a clear overview of the study with the research problem, methodology, conclusion, and even keywords. The sample size was large enough to show statistical significance and portray a generalization. The study was able to denote a real-world clinical setting, making it easy, less expensive, and can be performed within the natural clinical setting. Next comes a guide for evaluating a healthcare intervention. Are the results valid? It's hard to tell. When it comes to internal validity, it is hard to judge because no independent variables were being manipulated, but the researchers tried their best to rule out alternate explanations for any effects observed. Looking at external validity, the article collects only data from a single geographic location and facility, but works with this by comparing it to other data outside of the facility. But because of this, one cannot be too sure that the conclusions drawn about cause and effects relationships apply to people in other geographic locations or other facilities. The only way to demonstrate external validity is to replicate results in different populations, places, and time periods, which the study did not do. Next, did the study use a randomized controlled design? No, it was a clinical observational study with no change in variables. And now looking at Melnick's and Feinout-Overholt's hierarchy of evidence, how strong is the study's design? Based on that, the level of evidence is a 4, which is moderate strength. The biggest weakness of the study is its out-of-date references. Although the article was published in 2013, literature ranged anywhere from 1984 to 2010. Much can change in 30 years. This article is also comparing results to older studies in the discussion section. The references, however, were accurately referenced. When I mention setting, I mean where the study took place. The study was done in a teaching hospital in India, a developing country where medical science is behind the US and where overall nutrition and health is poorer, so results can be quite skewed. How much of this, you can ask, can we apply? The next weakness has to do with the nature of the study's design, which is again an observational study design. There is no way to prove cause and effect, but it does avoid ethical problems of experimental exposure to risk factors. Can you imagine asking people to stop eating iron, folate, and B12? The potential for bias is higher in observational studies. Sampling bias, for example, only those coming in to seek medical care are being examined. Volunteer bias is another example. Only those who consent to being part of the study is being sampled. And based on the study's strength of evidence and weaknesses, how can you use the study's outcome in planning nursing interventions? Since the prevalence of anemia in this clinical-based study was significantly higher than community-based studies, we should advocate for anemia evaluations, micronutrient status, and blood stool with geriatric patients. Failure to evaluate anemia in elderly populations could lead to delayed diagnosis of potentially treatable conditions. We also want to educate on the importance of micronutrients and nutrition. Anemia in elderly populations are more dangerous due to other comorbidities and lower energy requirements of the elderly, which leads to decreased or imbalanced food intake. From this, we can form our own nursing diagnosis: imbalanced nutrition, less than body's requirement related to poor appetite.